Securing a mandibular denture with small diameter implants. The patient presented with old dentures. She'd lost vertical dimension and they were not secured by implants. So here she is before and after. These are the implants that secure the mandibular denture. Standard of care is when you're placing implants, you should have at least a lateral cephalometric radiograph and a pantograph. You may want a cone beam, and I make use of periapical radiographs, as I'll show you here in just a minute, to determine depth of implants. So you can see she's got the ideal implant is placed through the trabecular bone and at least the tip in the cortical bone. That's not always possible because the longest small diameter implant is 18 millimeters. I'm wiping the ridge with Paragard. Now in this case, I'm not modifying the ridge, and more often than not, I do modify the ridge. I've found from many surgeries that when a patient teeth have been missing for a fair amount of time, that ridge becomes knife-edged because oftentimes the buccal plate is lost when the teeth are extracted. And when the buccal plate is lost, the ridge becomes knife-edged. Don't forget this about small diameter implants. They're the same as root form implants if used correctly. Small diameter implants have gotten a bad rap because too many people are trying to place small diameter implants in a knife edge ridge. You've got to flatten that ridge so that the small diameter implant is being placed in a flat surface. No different than placing a wood screw in a wall. But this one was okay. We had plenty of bone and the ridge was relatively flat. So I'm using these color transfer applicators to mark the center of the ridge, and you dip the tip of this applicator in water, then you can mark the center of the denture. Then you push that to place, and that shows you exactly where the center of the ridge is. Now, even though I'm not using that old denture, it's helpful to show me exactly where the center of the ridge is supposed to be, or at least was supposed to be when she had that denture fabricated. So I want to know the depth from the coronal cortical plate to the mandibular cortical plate. And you can see that's about 12.5 millimeters. With the pilot drill, I'm going to drill down 10.5 to 11 millimeters. And then I'm going to take a radiograph with the pilot drill in place, so that I get an exact reading. This is a way to determine that depth without a cone beam. I love cone beams. They're fantastic, but sometimes it's just very inconvenient, or the cost, or any number of reasons. A cone beam is just not in the cards. And so this is a way of determining that depth, or if you want to know the distance between the alveolar crest and the middle nerve, or the inferior alveolar nerve, or a sinus, you can use this same technique that I'm about to show you. So I'm placing the pilot drill and watching these black lines, and I'm going into the mandible, drilling into the mandible about 10 millimeters, where I know I'm safe. I know I'm not going to go through the apical part. Then I'm going to measure from the tip of the pilot drill. I've left the pilot drill in the bone and taken a radiograph. I'm going to measure from the tip of the pilot drill to that cortical plate in the apical part of the mandible. That's about 3.19 millimeters. So I'm going to measure, I'm going to add this length to my pilot drill and place an endo stopper, rubber stopper. An up and down movement, lots of water, and I know I can go to that depth. You don't have to drill to depth if you're not going very far into that cortical plate. But if you are, remember, because a lot of times if you're just in trabecular or medullary bone, you just pierce the coronal cortical plate, and then the implant bites into that medullary or trabecular bone. If you hit the cortical plate, the apical part of the mandible, the implant will not progress into the cortical plate, so you've actually got to drill into the cortical plate at the apical part of the mandible if you want to extend your small diameter implant into that cancellous bone. I'm going to check this frequently because I want this implant slightly slanted to the lingual. I want all the threads to be in the bone ideally, But the main thing is I want the flat shelf of the implant to be slightly subgingival. Now, I use the finger driver first, and then I use the ratchet wrench. Once the implant's in place, I should not be able to advance the implant anymore with the finger driver. It should take the winged wrench or the ratchet wrench to advance it. You want at least 7 millimeters between the center of this implant and the center of the adjacent implant, about 5 millimeters between the implants. So you have room for the housings. On this, I've done the same thing, and I check it with this occlusal mirror to be sure that they're about parallel. One of the things about small diameter implants that we really like is they can be divergent up to 30 degrees from adjacent small diameter implants. They don't have to all be parallel. As a matter of fact, there's somewhat of an advantage to the implants not being exactly parallel because it increases denture retention. So I'm using the finger driver as far as I can. You'll get to a point, or should, that you can't advance it any further. Then you can either use the winged wrench if you've got enough room, or the ratchet wrench. And you just want to turn it a quarter of a turn, slowly, quarter of a turn only, because you don't want to heat the bone. Then I'm coming back and checking with the finger driver to be sure I can't advance it anymore once I've gone to depth with my ratchet wrench. Now, we're being very careful not to get back to the mental nerve distally. There are ways of telling radiographically if you get close to it. We'll go through those in other dental minutes. It wasn't an issue in this case because the mental nerve is considerably distal to my most distal implant. But you do not want to, you don't want to place an implant into the middle nerve or the inferior alveolar nerve. Again, the finger driver, then the ratchet wrench. This case is a bit out of the norm because I am drilling to place. Normally, when you're placing small diameter implants, you don't drill to place. You just drill through the coronal cortical plate into the trabecular or medullary bone and then screw it to place. In this case, I'm drilling to depth because I'm going into the cortical bone, the cancellous bone, in the apical part of the mandible. And I won't be able to advance my implant into that bone if I haven't drilled into it. Multiple times, he's the person that invented the small diameter implant. And in his opinion, it's always advantageous if you can end up with the tip of the implant in cortical cancellous bone. Doesn't always happen, but that's ideal if you can do that. Screwing it to place, and I want the flat part of the implant, the shelf or the collar of the implant, just subgingival. I'm checking these with the finger driver or the finger wrench to be sure I cannot advance them anymore. Now think about that, because you're not going to be measuring 35 Newton centimeters of torque with small diameter implants. You're just going to be ratcheting them to place or screwing them to place with the winged wrench or the T-wrench. So this is critical. Once you've screwed them to place with the ratchet wrench or the winged or T-wrench, go back with this finger driver and be sure you can't advance them anymore. If you cannot advance them anymore with the finger wrench or finger driver, there's a high probability that that will be a successful implant, that it will osseointegrate. If you can advance it with the finger driver, there's an issue with the bone. Take that one out, move it, place it in another position. So I can't advance these, screwing it as hard as I can. So you can see this is perfect. Victor Syndax would be happy with these because I've advanced them into the cortical plate in the apical part of the mandible. So placement of small diameter implants in the mandible, extending into the apical cortical plate to secure a lower denture.